I'm going to get started. We're going to get started here in just a time. Great. Thank you. So for some of the physicians that may not know who I am, my name is Alex Bagley. I'm supervisor for the Cardiopulmonary Physical Therapy Service here at Cornell Medical Center. And today it's my pleasure to introduce Dr. Greenspan, a preeminent figure in the area of cardiac and pulmonary rehabilitation. Dr. Greenspan has over 20 years of experience in the field of cardiopulmonary, cardiovascular rehabilitation and diseases. He began his professional career at New York University's Rusk Institute for Rehabilitation and served there as the chief physical therapist in their cardiac prevention and rehab center there. He subsequently joined the teaching faculty at NYU and was awarded the title of Master Clinician in the area of cardiovascular and pulmonary physical therapy. He's also taught at Dominican College, New York Medical College, Long Island University in the areas of cardiovascular and pulmonary pathology, diagnosis and management, and he's currently the Pulmonary Rehab Fellow Coordinator for Weil Cornell Medical Center. In 1998, Dr. Greenspan founded the Pulmonary Wellness and Rehabilitation Center, a Manhattan-based physical therapy practice specializing in the care of patients with cardiovascular and pulmonary diseases. Under his direction, the center has conducted over 60,000 exercise sessions and been named, quote, best of the United States, end quote, in the area of cardiovascular and pulmonary physical therapy. Dr. Greenspan earned his Bachelor of Science in Physical Therapy from SUNY Upstate Medical Center and his Doctor of Physical Therapy from Dominican College in 2006. As if the preceding is not impressive enough, Mr. Greenspan is also a New York State certified emergency medical technician and advanced cardiac life support provider, a professional scuba diving international open water instructor, an underwater naturalist with a passion for shark photography, a musician, an artist, and even has a clothing line. Ladies and gentlemen, Dr. Greenspan.
Thank you, Alex, and thank you to Dr. O'Dell for inviting me here today. I had a bunch of jokes planned, but in light of last night's debate, I feel it would be redundant. So I just want to say I don't usually use PowerPoint. I'm going to use it today, but if you have questions, please stop me. I doubt you're going to throw me off. If you do, it'll be more entertaining for you. But I want to make sure that we get today what you guys want out of this presentation. So I'm going to start and this. Okay, so my practice is on 38th Street between 5th and 6th Avenues, and basically the one thing that unites all my patients is that every single person who comes to me is short of breath for one reason or another. So it may be a pulmonary issue, it may be a cardiovascular issue, it may be an anxiety issue, it may be a conditioning issue, but everybody who comes in is short of breath, and I'm sure that's pretty similar to the patients that you see in your cardiopulmonary service. We do see patients with obstructive disease, so COPD, asthma, emphysema, chronic bronchitis, bronchiectasis. We see a lot of restrictive and interstitial lung disease patients, and we see a lot of pre- and post-surgical patients. So we see people pre-transplant, post-transplant, and pre- and post-lung surgery, and pre- and post, surgery for cancer. So one thing that I think has made us, very successful in getting results with our patients is the first session. The first session that you spend with your patient and your evaluation and the time that you spend getting to know them in that first point is really going to set the stage for everything that happens over the next 6 months or however long you see your patient. And it's really important. I know it's a little bit different in a hospital, but the first time you see somebody, it's really important that you give them enough time to really say what they want to say, to tell their whole story, so that they don't feel rushed, so that they really feel like they're telling you what you want and you are getting what you need to provide the proper care without hurting your patient. Because as you know, the last thing we want is for somebody to come to us and get hurt. So as far as chief complaint, like I said, the thing that I hear most often is going to be shortness of breath, and the thing that I'm going to hear next often is that I can't walk. And almost always, these things are going to be directly related. So, as you know, most people don't start off just level 10 short of breath. So most people start to get short of breath at high levels of activity, walking upstairs, walking uphill. They find ways to avoid those activities, and as a result, the whole body deconditions. They start to get short of breath at lower levels of activity. They find ways to avoid those, and so on and so forth. The other thing that goes hand in hand with this is anxiety. I think there are probably very few things in life that are as, really anxiety-provoking as not being able to breathe. So patients are walking out, if they know that every time they walk up the subway stairs, they get this pressure in their chest, they can't catch their breath, and people are running up the stairs behind them, annoyed that they even have to stop, they are going to find ways to avoid those activities. So our goal is to break into that cycle by, number one, teaching people more effective breathing techniques, and then exercising them vigorously and aerobically so that their bodies get better at using oxygen, but also strong. I think sometimes we make the mistake of saying, you have COPD, therefore shortness of breath is your only issue, or your body doesn't use oxygen as well. And shortness of breath, we see patients who have 98% oxygen saturation that are still super short of breath, and there's other issues, including mechanics of breathing, including anxiety, including level of conditioning, that play equal a role as to their lung disease themselves. A lot of times we do testing on people, and their lung disease isn't even that bad. But if their vital signs are good, then we know we can push them, and our goal is to always get the most vigorous activity that we get. I think one of the mistakes people make is they'll go into a place, they'll exercise somebody at 1.4 miles per hour, and I'm not talking about the patient who's coming out of the ICU, I'm talking about patients that are living their everyday lives, but they're exercising for long durations at workloads that are less than their everyday life. So as an example, if you are using the exercise bike at a 1.8 MET level, you can do that till the cows come home, but that's not going to help you walk up the subway stairs. So our goal is to trick the body and to trick the patient into being able to work out harder than anything that they have to do in their everyday life. But of course, safety, okay? If we come in and, 5 out of every 10 patients we have keel over because we work them too hard, that's not going to be effective, and those patients are never going to come back. Other things, as far as HPI, history of present illness, it's really important to start from the beginning and ask people, how did you get here? And one question I like to ask people is, how far back would I have to set the clock for you to be satisfied with where you are? And for the person who's been short of breath for 6 months, that's a lot different, and the care is going to be a lot different than the person who's had COPD for 20 years. But it's really important to say, when were you first short of breath? Where did that start? What were you doing before? And how did we get to this point? And what you find is that most people, I think a lot of times we think of chronic disease, with like heart disease, we say, how does atherosclerosis develop? And I think people think of it as sort of this linear uphill climb, whereas it's not really like that. Same thing with shortness of breath. I think people think that it sort of progressively, linearly goes short of breath, so that we can actually predict, hey, guess what, in 6 months from now, you're only going to be able to walk 600 feet. Whereas in fact, what happens is we have an event, that event brings us down, and then we stable out for a little while, or we get better. And then we have another event, and we come down here. And then we have another event, and we stable out. But what happens a lot of times, and one of my pet peeves, is that when people talk about lung disease, they say it's a chronic progressive disease that never gets better, and you just get more and more short of breath until you die. And that's what patients go on the internet and read. And that patient has no hope now because they're terrified, because not only are they getting short of breath every day, but they're like, what's going to happen to me over the next year? Am I just going to keep getting weaker and weaker? And we can break into that cycle, especially because I'll tell you, in about 80% of the patients, it's not just their lung disease why they can't walk. It's not their lungs that are limiting their activity. It's their muscles, it's their conditioning, it's their fear, and those are the things that we could really have a huge impact on patients. And one of the things also is that education. We want to teach our patients everything that they can do to help them get better. Excuse me, okay. So when I see a patient for the first time, I have 2 goals. My goal is to make that patient comfortable. My goal is for them to love our center, to want to come back, because let's face it, A lot of people don't know why they're here. Will say, why are you here? I have no idea. My doctor told me to come here. They don't know what we do. They don't know, what to expect. The last thing they want to do is hop on a treadmill, because very often, think about it, how did our patients get diagnosed? Treadmill test, right? Or how did our patient get diagnosed with heart disease? Treadmill test. Or they had that experience where all of a sudden they can't breathe. They throw them in a chair, they oxygenate them. So they say, have you walked on the treadmill before? Yeah, I failed the test. That's how I got here. So patients are coming in, and we'll talk about treadmill testing in a little while, but they're coming in terrified. So my first goal is to get them comfortable with the facility, but then to really get a good handle on what they do. And I have 3 things that I really worry about when it comes to risk stratification, okay? One of them is coronary insufficiency, arrhythmia, and CHF heart failure. So you may think, why am I worried about these 3 things in particular? If it's not obvious, okay, these are the things that could potentially kill your patient. And that's the last thing I want. So, when they come in, I'm not just saying, do you have heart disease? Another thing in terms of doing your assessment, it's really important that you communicate with your patient at their level. And it sounds obvious, okay? I know probably some people are sitting there saying, I've been doing this for 20 years, I don't need you to tell me how to communicate with my patient. But I've seen this person, therapist, doctor, hot dog vendor, ask a patient a question, and the patient doesn't even know what they're talking about, they can't hear them, they misunderstand the question, and then somebody else asks the same question in a slightly different way, and it triggers a beautiful, lifelong conversation, and they find out they had the same cousin in Manitoba. So one thing I want to do is I want to really communicate with my patient in a way and ask them the questions that I really need to know over and over again. Now let me plant another seed in your head. Most of our patients, our pulmonary patients, come in. Their symptoms are shortness of breath, right? We know shortness of breath is obviously a pulmonary symptom. It could also be a cardiac symptom. But here's another thing, and why heart disease is so often missed in patients with pulmonary disease. It's because the patients don't get up to a high enough level to elicit heart disease. So if walking a block is all you could do, or walking a half a block is all you could do, you may never reach that threshold of ischemia. And when you go to your doctor and you say, oh, I'm getting this chest pressure, or I'm getting this shortness of breath, a lot of times the assumption is, well, it's your asthma, it's your airways, it's your COPD. And so a lot of times after patients come to us and we start conditioning them, we actually start to see signs of heart disease as well. So always, these are things, and it's not something that you do one time. With cardiopulmonary patients, more than any other patient, the assessment is ongoing and constant, because I look at it like a flight, okay? This plane may have had 999 safe flights, but if I'm on 1,000 and that flight isn't safe, I don't care about the other 999. It's the same thing with patients. I could see a patient for years on end, and they're great, stable, everything's cool, and then they get that one day that something's wrong, and if you are so complacent with this patient because you know them for 3 years, that's a mistake. So this assessment is ongoing. It's every time we see the patients throughout the course of the workouts themselves, and it's at the end of every workout. More so than anything else, cardiovascular and pulmonary patients are physiology-based. It's all physiology. It's all basic physiology. And those are the things. To become a great cardiopulmonary physical therapist or rehabilitation professional, it's not the stuff up here that you have to know. It's the stuff from Physiology 101 that you've forgotten or haven't thought about, in 20 years since you've been a physical therapist. So that's the bread and butter. That's where your everyday cardiovascular and pulmonary patient is going to be seen. And then the other thing is that unlike an orthopedic patient where you look at the knee, it looks like 90 degrees, you measure it, it's 85 degrees, you can see about what you're seeing. What you see is pretty much what you get, okay? But with cardiopulmonary patients, somebody could look great, and inside we don't know. That's where, it's like a pilot that's why you have to rely on your instruments and your measurements, and not just a measurement at the beginning of the session, because things can change, okay? A lot of times I hear people, they'll say, I went to this program, and what happened is they monitored me at the beginning of the program, and then they monitor me when I sat down at the end, when my workout's done. And to me, that's like, if you want to know how a plane is in the air, you don't, before takeoff and after landing, that's too late. So again, risk stratification, we want to keep our patients safe. With this population, there is an inherent risk that's probably greater than most people that we see. But keep these things in your mind every time you see them. And the other aspect of this is, for the people that don't do cardiopulmonary rehab, take out your stethoscopes and your blood pressure cuffs anyway, because I run a course called Cardiovascular of the Rehabilitation Patient, because every rehab patient is somebody with a heart, with the lungs, and if you have that 100-pound overweight diabetic who just had an amputation, I can promise you that person's got atherosclerosis in their heart, and I worry much more about that patient than I do the patient who just came out of a quadruple bypass. So keep those things in mind. Medications, okay? Few topics are lesser understood in the pulmonary world than how to take your medications, okay? Especially when it comes to the inhaled medications, and they have names like Anoro and Striverdi and Spiriva and so on and so forth. And one thing that I will say is that how your patients take their medications can make a gigantic difference in terms of how they do every day and how they do particularly around rehab, okay? I look at medications kind of like a brace, okay? When I look at, rehab patients, I've been trying to think of something for really about 15 years, and I thought of it this week, but the medications are really like a knee brace, okay? Or a brace of any type of orthotic, and the breathing techniques are really, it's like a walker. That's the assistive device, okay? A lot of people think the breathing techniques, that's the treatment. That's not the treatment. The treatment is going to work. That's going to work with almost every patient with conditioning, but we need ways to trick the body into getting up to higher and higher levels, and the medications are huge. So if you're treating cardiopulmonary, or rather pulmonary patients on a regular basis, make it your business to know the medications. Make it your business to know the different classifications of drugs. Know what the anticholinergics do, know what the beta-2 agonists do, know what the corticosteroids do, and then teach your patients about that, okay? Now, I know you're not pharmacists, some of you are not physicians, but even as a physical therapist, a lot of times people look at the therapists, PTs, OTs, and they say, you're just a physical therapist, you don't need to know these things, or you're just an OT, you don't need to know these things. Wrong. No, the thing is that, you may not have to know them, but you know what? You're the person that's going to spend the most time with these patients. I spend 3 hours to 4.5 hours a week with my patients, and they're on the treadmill. Trust me, treadmill is pretty boring, okay? But that's a perfect time to say, what medications are you taking? Do you know how to use them? Let me see you use them, right? Because a lot of times you see the patient go, okay, if they're not taking their medications effectively in a way that it's actually going to get to the area that we want, it's like I'm taking a Tylenol, but I can't get it into my mouth, okay? So again, and the other thing is when you're doing your evaluation, okay, I remember in the hospital, I'd get a sheet, I'd go, I'd see people, I'd get their medications from the chart, but with all due respect, with the exception of Mike Stipe, I don't know any of you, so I am going to take, I'm not necessarily going to take what you say. It's like saying, yeah, I put gas in the plane before we came. I like you, but I want to make sure that I'm doing all my own assessment myself. Because if something goes wrong, I don't want to be like, Alex told me it was okay. Because it's not going to be Alex who's in trouble, okay? So another thing is that in terms of building a rapport with your patient, in terms of developing the confidence of your patient, we probably see the same 20 medications over and over and over again. So if your patient says, I'm taking omeprazole, and I'm taking asthma cords, I'm taking this and this, and you say, okay, so you have hypertension, you have high cholesterol, you have GERD, and you have this. Boom, you're golden in that patient's eyes, and you should know it. You should have an idea of what these medications do so that you can teach the patient, but also so that you can teach the patient how to maximize the effectiveness of the medications over the course of the day and before each rehab program so that you can get the most out of each and every workout. Pulmonary medications, very important. Cardiovascular medications, very important. And other medications, less important. As far as a systems review, I go through every system with my patient. I want to ask them questions, okay? And again, this is where I'm asking them questions in multiple different ways to make sure that they understand what they're talking about. So this is what my systems review sounds like when I'm going over it with my patient. So do you have any neurologic problems? Okay, now this is one of those cases where I'm talking about where I say, do you have any neurologic problems? And my 85-year-old patient, maybe she hears me, maybe she doesn't hear me, maybe she speaks English, maybe she doesn't speak English, but she doesn't know what neurologic is, right? So if she's never heard that word before, then she may say no, when meanwhile, the answer may be yes. So I'll say, do you have any neurologic problems? By that, I mean, have you ever passed out? Dizziness, stroke, seizure. Okay, everybody knows if they had a stroke or not. Actually, that's not true. Sometimes they don't. But have you ever passed out? Dizziness, stroke, seizure. These are important ones, okay? Not everything that we do. Like, I There are certain things that are going to be less important, like if you have a mole on your arm, I don't think that's going to affect my treatment a lot, but if you get dizzy or you pass out, I want to know why. And that could be a neurologic issue, that could be a cardiovascular issue, that could be a peripheral vascular issue. So I want to, and then if you say, yeah, I do get dizzy sometimes, well, tell me about that. What are the conditions in which you get, well, when I first get up in the morning, I get dizzy, okay? I have to sit at the edge of the bed for a while. So now I'm thinking orthostatic hypotension, okay, or postural hypertension. Or they say, well, you know, when I'm walking, I can walk for about, 5 blocks, but on the 6th block, I have to stop and I start to get dizzy. But all of these things are going to tell you things about your patient so that when they're up on the treadmill, we can make the adjustments we need to, and we can try to correlate that with the vital signs that we're seeing every 5 minutes, and then we can also change the workout to maximize that and to, believe it or not, change the vital signs. So if somebody comes in and we know that they have orthostatic hypotension, then we're going to start them with lower stuff first, to build them up, or it could be that fatigue is a factor. So if fatigue is a factor, we're going to do the hard thing first. If aerobic capacity is a factor, we're going to do the easy things up and build them up to the hard stuff when they're mostly aerobic. But you want to go through these things, and particularly the ones that are going to affect your workout and your rehab program. All right. Head, eyes, ears, nose, throat. So do you get a lot of headaches? How's your vision? Double vision or blurry vision? Do you have cataracts or glaucoma? Don't ask them if they wear glasses if they're wearing glasses, because then they're going to think you're really stupid, and then they're going to know you're not paying attention. How's your hearing? Do you have any ringing in the ears? What about vertigo? So ringing in the ears, vertigo, dizziness, all these types of things are important because when my patient is up on the treadmill and they say, I'm feeling dizzy right now, I want to correlate that. Well, if you have an inner ear problem, that's different than if we check your blood pressure and now your blood pressure is 40 points lower than it was when you started. And again, you're putting these things together little by little, and all your answers are not going to come in that first session, but I just want to make sure that I can keep that patient safe long enough to do the exercise test. And actually, that's not true. I still want them to be able to leave my practice, go home, but you want to make sure that you're not going to hurt them in the first visit. Sinus trouble, sore throat, hoarse voice, denture. So sinus trouble is really important because we are going to try to get patients often to breathe in through a nose. So if patients that have a deviated septum, or have sinus trouble, or have allergies, we want to keep those things in mind, and we also want to make sure, we also want to keep tabs. When is our patient getting sick? We don't want to wait until they have a full-blown flu before we say, hey, you need to see a doctor. And so by checking in with these things periodically, you can cut things off in the past. All right, this is the second biggest slide here. The first one is risk stratification. The reason why this one is so important is because between your neck and your belly, okay, we have a lot of stuff going on. We have a lot of systems. We have the pulmonary system, we have the cardiovascular system, and the GI system. And the reason why I put these three together on one slide is because the symptoms of these can often get mixed up, okay? Somebody can start exercising and start to experience a discomfort in their chest. And of course, we worry most about the heart, but it could also be reflux, okay? Somebody could be, have airway tightness, and of course we worry about the heart, but it could be just bronchospasm. Or somebody could actually be having a heart problem, and they say, no, it's just my airway tightness, okay? The last thing you want to miss is the patient who's having a heart problem, okay? So the thing is, the reason why I say these things is because it's important to keep these in mind. Whenever somebody reports a symptom, you want to thoroughly assess that symptom. And just because they have severe COPD, don't assume it's the COPD. Or just because they have heart disease, don't just assume it's the heart disease until proven otherwise. And I'll go a little bit more into this in a couple minutes. So as far as pulmonary disease, have you ever been told you have asthma? Okay, and I want to ask these questions in a number of different ways. Do you have COPD? Most people say, what is COPD? Many of you may not have realized during the debate last night that COPD also stands for the Commission on Presidential Debates. Coincidence or not? So other things, and then when you talk about COPD, break it down for them. Have you ever been told you have emphysema or chronic bronchitis? Okay, right? Because we've all had patients that, do you have COPD? No. Do you have emphysema? Yes. It's like, so you have to explain to me, if you have emphysema, you have COPD. If you have chronic bronchitis, you have COPD. You can have COPD without having emphysema. you have chronic bronchitis. And you could have COPD without having bronchitis if you have emphysema. But you want to not assume the patient knows what COPD is, okay? Now we're hearing a lot about asthma COPD overlap syndrome, which that's a whole thing on itself. Have you had pneumonia in the past? Are you coughing? Okay, very important because we want to take responsibility for the whole patient. And we know if that patient has bronchiectasis, if that patient has non-tuberculosis mycobacterium, if that patient has chronic bronchitis where mucus is a regular part of their day, we want to teach them about how to keep their lungs clear and free of infection as opposed to treating them once they get an infection. Now, I'll ask somebody, are you coughing? It's like a little flow sheet. So, are you coughing? No. Great. Are you coughing, sir? Okay. So, are you coughing? Yes or no? If the answer is yes, I'm coughing, are you bringing up mucus? If the answer is no, my question then becomes, well, is it that you don't have the mucus, like in a patient who's mostly emphysema, or the patient who's got pulmonary fibrosis, or is it that you have the mucus and you just can't clear it? Because what a lot of people don't realize is that the cough mechanism is really only effective from here up. So it's like a ketchup bottle. If I have all the mucus down here, I could shake that bottle till the cows come home, but until you put it in the right position, then you're not going to get your ketchup out. Same thing with mucus. And then the other thing is that, you know, whereas 25 years ago, the only thing we had was the flutter valve, which is the godfather of positive expiratory pressure, but it's not the most effective device. Now we have the aerobic, and now we have the acapella, and that should be a part of anybody's daily routine who does have a regular problem with secretions. And then if they are bringing up mucus, what color is it? Is it clear, white, or color? And then ask them, is it clear, white, or color? Okay? Sometimes I think, well, I don't know what color it is, I don't look at it, but break it down as simply as possible for them. Ask them the question in as many ways as possible. Is it thick or thin? Is it clear, white, or colored? It's colored, what color is it? Now, some people with bronchiectasis or NTM or MAI or MAC are going to have thick colored secretions as a regular basis, but we want to establish a baseline now so that when we see a change, we can get on the phone and speak to that physician. And if you know, we want to have as much information as possible. I've never been of the mindset that you're a physical therapist, you don't have to know this, okay? Or you're an occupational therapist, you don't have to know this. Or you're the guy who cleans the bathrooms, you don't have to know this, because you never know. I was lucky, I was trained by 2 physicians and a nurse at NYU, and the bottom line is the more we know, the better we're going to communicate. If you call up a doctor and say, I want to talk to your patient, I want to talk to you about your patient, and he's like, well, what are the vital signs? And you're like, I haven't taken the vital signs. They ask you questions, you don't know the answer to these questions, they're not going to pick up your phone call when you call, okay? But if you have all this information and it looks like you understand the big picture of the patient, you have a much greater chance of getting success with that. Other things. Shortness of breath, yes. Are you wheezing? Okay, wheezing could be cardiac, it could be asthmatic, it could be other things. And then have you had any heavy exposure to dust or chemicals? I run a couple of thousand person Facebook group for patients with lung diseases and cardiovascular. You would be amazed at how many people have been diagnosed with a chronic disease and don't really understand their disease. Or they've been told that they have emphysema, but they never smoked, but they worked in a coal mine for 15 years. So now there's much more emphasis on the interstitial diseases, and that's a whole topic unto itself that is very complex. Very few people understand it, but by you having that understanding, we can, we want to be on the forefront, especially where I am, where I'm in private practice in a place on 38th and 5th. If something goes wrong in a hospital, you have a lot of people there to help you. Even if you don't know what to do, if you scream out, oh my God, a bunch of people are going to run to help you. On 38th and 5th, we're on our own for at least a little while. So, I try to make it my business to know as much as I can. Heart trouble when it comes to the when it comes to the systems root. Are you having any chest pain or pressure? Do you get any squeezing feelings in your chest? Are you having palpitations? Ask it as many ways, because people think chest pain, you go, what are they, a different idea pops into people's mind. Is it sharp or dull? And then there's something else here, which is this, which is, as far as this is a very good way to remember things. So it's OPQRSBI. I don't know if you guys have heard about this before. But in terms of describing a symptom, so I want to know about the onset, okay? So tell me about when this began. I want to know about, and don't you don't have to write these things down. I'm gonna make the video to this available to you on our website, so you will be able to watch this. Please listen and don't write, because I talk fast anyway, but onset, what happened, how did this become, how did this begin, provocation and palliation. So is there anything that makes it better or worse? So if somebody says, I'm having chest pain now, and I go, and I press around on it, and I say, is that the pain you're talking about? We know it's not the heart, because the heart doesn't work that way. The quality of the pain, so is it sharp or dull? Radiation, so does it stay in one spot? Does it move down your left arm? Does it go to your neck? Does it go to your jaw? Another thing is keep in mind the atypical signs of ischemia, so jaw, neck, not the classic left arm radiating pain, but also back pain. So if somebody's on a treadmill and we bring them up and all of a sudden they're starting to report cramping in their shoulder blades, or they start to feel a little something up here, I assume it's cardiac until proven otherwise. S is severity, so on a scale of 1 to 10, how bad is a symptom? T is timing, and I is intervention. So very quickly, I'm going to go through GI. So have you lost or gained any weight? Do you have any GI or stomach issues? And again, the one that's really important in particular is GERD, because 90% of our patients that we see, my average patient is 80 years old, but tons of patients have GERD, and GERD is often, stimulated by position. It's often stimulated by activity, especially if you have lung disease and you have big lungs in here taking up a lot of room in the chest, and then you get exercising and that stomach starts to push acid up, and it could go to the neck. So that's all the things I just warned you about with heart disease, and it may just be GERD, and sometimes, just taking Maalox before the session can help, so on and so forth. Okay, do you have any urinary problems? Are you on a diuretic, okay? Do you have any vascular or circulation problems? Look at their legs, okay? Look at the amount of edema in there, because pulmonary patients and cardiac patients can have cardiac edema. Do you have any blood disorders? Do you have any thyroid trouble? Are you diabetic? Osteoporosis? Do you have any skin problems? Do you have any musculoskeletal problems? And as far as musculoskeletal problems, again, most people don't know what that means. Do you have any joint swelling, stiffness, pain, arthritis? And the reason why this is so important to ask before you get a patient started on a program is because a lot of our patients come in, they haven't exercised in 40 years, right? So if we're going to all of a sudden start working them out twice a week, they may develop some orthopedic or overuse problems, and we want to try to cut that off as quickly as we can, or prevent it, rather, I should say. Okay, other things, smoking history, who do you live with? Do you live by yourself? Do you live in a house or apartment? Do you live in stairs? And then you want to know about their goals, okay? So what's important to the patient should be your primary importance in addition to keeping them safe. After that, I'll take their vital signs, okay? Check your patient's heart rate and rhythm. Ideally, if you have an EKG, that would be best. Check their blood pressure, check both arms, because a lot of times you will see differences arm to arm. So if you only take one and there's a 30-point difference and you take it on the low arm, you're always going to think their pressure is lower than it is. If they, if you only take it on the high arm, you're always going to think it's higher than it is. But if they have a difference, then check that out periodically. Oxygen saturation, physical exam. When most cardiac patients or pulmonary patients come to me, active range of motion, passive range of motion, and manual muscle testing, it's almost always all the same. Okay, so it's like most people do have functional, within functional limits, especially if they're out living their lives and if they're able to do most things. Most of their passive range of motion is within functional limits. Manual muscle testing is usually somewhere between 3 and 5. Okay, so it's going to look the same. And I'm not doing formal testing, but I want to know about my patient's strength, and is that a limiting factor in addition to their respiratory issues. Listen to their lungs. If for no other reason you want a baseline, you want to know if that patient comes in and says, I'm coughing more, God bless you, sneezing more, one more, and I'm going to have to ask you to leave. Other things, again, if a patient comes in, they're coughing up mucus, all of a sudden it's different, listen to their lungs, and again, if you've never listened to their lungs before and you don't know what the baseline is, you don't know if there's a change or not. And then another thing, edema and pedal pulses, because a lot of times, something that we don't often think about, but a lot of times a patient will come in, they'll have edema on one side, they'll report pain in their calf, and if you've never checked their pulses before and somebody does have vascular disease, they may have a diminished pulse anyway, peripherally, so you want to have a baseline for that. And if ever there's a doubt that somebody might have a DVT, don't err on the side of dislodging that on your treadmill. Functional assessment, bed mobility. Do you have any trouble getting in and out of bed? Do you have any trouble getting up from a chair on the toilet? How far can you walk without stopping? Again, how far can you walk without stopping? Do you actually have to stop? And then you want to know, what is the thing that makes you stop? Is it shortness of breath? Or is it fatigue? Is it lower extremity fatigue? And then do they use any equipment or assistive devices? When it comes to exercise testing, okay, there's a lot of different ways to do it. Most people are familiar with the 6-minute walk test. For people that are doing more formal testing, the bicycle is used in some programs in the city, the treadmill is used in other programs in the city. I use the treadmill. I don't think the 6-minute walk is ideal if you have access to other things. I think if it's all you've got, it's effective and it's been proven to be repeatable, but I think there's too many variables. I've actually heard people say, make sure you don't do too well on your 6-minute walk test, otherwise they're going to take away your rehab. So keep that in mind. The patient has too much control over the test for me to really believe it's accurate. So your level of motivation may be very different than my level of motivation. So, and then the other thing is that where people do the 6-minute walk test is totally different. So if I only have 10 feet that's going back and forth, that's a lot different than doing it on a quarter mile track. I could give an hour on why I don't like the 6-minute walk test. I'd rather tell you what I like. Bike test I don't love because you can bike till the cows come home, but most people don't commute here by bike that are over 70 years old. So you can bike till the cows come home, it doesn't mean you can walk. Most people here want to be able to walk. Now, let's talk about treadmill testing. Does anyone here do treadmill testing with their patients? Okay, but I'm sure you've seen stress test reports, you've interpreted stress test reports, right? So there's a big issue with pulmonary patients, which is that very often they're not being tested on the best test for them. So if you go to a stress lab, okay, most people are being tested on the Bruce protocol. Are you guys familiar with the Bruce? Okay, so we've seen it before. So the Bruce protocol starts at 1.7 miles per hour with a 10% incline. So think about your average 85-year-old patient, and if you put them on at 1.7 miles per hour, 10% incline, within the first couple of seconds, they're going to be thrown off the treadmill. Or a lot of times we'll get a treadmill report that says the patient tolerated 1 minute and 7 seconds of the Bruce protocol negative for ischemia. And I'm like, okay, but that's, or I'll get something, I won't name the institution, but I'll get something from where they'll say something like, patient exercised at 1.4 mets, and the workout should be 70% of that. And I'm like, well, what does that mean? That means, okay, have a seat, here's a drink, can I put your feet up? We want to keep in mind what is the limiting factor, okay? So the Bruce protocol is obviously the wrong protocol for pulmonary patients. It's the right protocol if you run a busy stress lab and you want to elicit cardiac disease as quickly as possible. But the other problem with the Bruce is if you look at the percent increase over the previous stage, so the Bruce goes up 52%, then it goes up 44%. If you could get to the next stage, it goes up 30%, and then it goes up 40% again. So that makes no sense. It's actually, if you could get through the first stage, then the rest, it's completely nonlinear and non-predictive. The modified Bruce is a little bit better because it starts at 1.7 miles per hour, 0% incline. It gives you 3 stages to get up to the first stage of Bruce. But again, if you don't get a long enough time and you don't get a vigorous enough result from these patients to actually have a hemodynamic response. So again, I'll say 1 minute and 7 seconds of the Bruce protocol, heart rate went up 10 beats, blood pressure went up 10 beats, oxygen saturation remained stable. That's useless to me because we didn't really test the patient. The protocol didn't allow them to do the best test. The one that I use is called the Benson protocol, and the beauty of the Benson, it was developed by one of my colleagues at NYU, Brooke Benson, an exercise physiologist, but the beauty of it is that it goes in 2-minute stages. It starts at 1 mile per hour. So if you can walk in, you could do 1 mile per hour. The next stage is 1.6 miles per hour flat. Then it goes to 1.6 miles per hour with a 2.5% incline. But if you look at the third column of the third column, you could see that every stage is going up by 25% over the previous stage. So you get a nice linear testing protocol, and with that, we could get nice linear predictable results in terms of heart rate, blood pressure, and oxygen saturation. All right, other things. So what do we want to do? So heart rate, blood pressure, oxygen saturation, RPE, dyspnea. So a lot of times you will get an order for a patient and it'll say cardiac precautions, okay? Okay, cardiac precautions mean different things to different people, or it may have blood pressure precautions that say, don't let the systolic blood pressure go up over 160 or 170 or 180, but there's been no testing prior to that. So they're really arbitrary, right? Unless you say, we're going to come up with something that's the same for everybody. But what I find a lot of times, especially with the pulmonary patients, is that the numbers are set too low. So what we do in terms of heart rate when we're exercising people, we will allow people to go to a maximum of 200 minus their age. Okay, so we know that the theoretical max heart rate in a healthy population is 220 minus your age. 200 minus your age, first of all, most people don't get up there because they are limited by either shortness of breath or lower extremity fatigue before they do, and before they have a true hemodynamic response. But the other thing is it builds us in 20 points of safety. And the other thing is that we're watching them on an EKG. So if you have the opportunity to use telemetry, to use an EKG, I would suggest doing it because 5 people could have a heart rate of 120 and those could be all different rhythms. So 120 in sinus tach is a lot different than 120 in AFib that's there for the first time. Blood pressures, if our patients are over 80, we will let them go to 180 systolic. If they're under 80, we'll let them go to 200 systolic. Now that's not our goal, we're not trying to get them up there, but for the average person, now that's a little different with the pulmonary hypertension patients, it's a little different with the patients with known vascular disease, but as a general rule, that has not gotten us into any trouble over the course of 75,000 visits. Oxygen saturation, I know there are people who are going to say it's okay to go down to 88, 87, 86. I don't believe it is. I think the second you go below 90, your heart starts saying what is going on here, and if it's going to act up, that's when it's going to do it. And then the other thing is, why would you want to go bare minimum? Okay, my goal with patients is to get the maximum workout possible. In 1995, we started seeing pulmonary fibrosis patients for the first time. So these patients would come in, their saturation would be 85% at rest on 6 liters of oxygen, and within the first minute or so of exercise, they were in the 70s or 60s. People were terrified of these patients, and they were disqualified from programs. They would say, you're too sick for the program. My boss and I, Dr. Horatio Pineda, said, this is terrible that we get these patients, they're so sick, they're so in need of care, but no one's willing to take them. And my feeling is that they're already, and I hate to, actually I'm going to backtrack that almost political comment I made, my feeling is their heart rates are high, their oxygen saturations are low, they can't do anything anyway. What do we have to lose by trying it? Okay, if they're walking around at home, we can keep them below ADL level, and we're not going to get into a jam. But what I'd rather do is give them as much oxygen as they need. And if I give an IPF patient 100% oxygen, okay, 15 liters of oxygen either by non-rebreather mask or Venturi mask, we can actually keep them saturated enough to be safe, and then we can start pushing them little by little, and that's what we did. And what we started seeing with these patients was they weren't dropping as low with exercise, or they were dropping low but at a much higher workload, and their resting saturations actually were coming up as well. So the key is, in terms of using oxygen, whether it's an obstructive patient or a restrictive patient, give them as much oxygen as they need to remain saturated to get the biggest workout possible, because it's the workout that is going to be what changes their life. Not the breathing techniques, not the oxygen, not the medication. So a lot of times people say, but with a COPD patient or a CO2 retainer, you can't give them oxygen because it's going to stop their breathing because they have a hypoxic drive. Not in the patient that's walking on the treadmill. Maybe in the patient who's in the ICU on a vent, but I've never seen it happen in 25 years as a cardiopulmonary therapist and 15 years as an EMT. So give them as much oxygen as they need. Another thing we'll look at, RPE scale and dyspnea scale. Don't make this more complicated than it needs to be. Don't say, well, level 6 and 7 are very, very much. The patient is going to lose you. Just say this. Go up to your patient. If their vital signs are okay and we're on the fence, do we push them or not? Are you working fairly light, somewhat hard, or hard? That's simple, okay? The middle 3. People can understand that. It's hard to delineate very, very mild versus fairly mild. Are you working fairly light, somewhat hard, or hard? If it's fairly light, we go up. If it's somewhat hard, we say, would you like to try another stage? If it's hard, we think about backing off. And then we can determine, based on our exercise test, their age-predicted exercise capacity. So this is the thing that we'll use based on MET level and age. I'm not going to go into the FITT formula. I'm sure you know it. And then we talk about our program, so monitored exercise. So the average program is 24 to 36 sessions. We monitor them by EKG, blood pressure, oxygen saturation at rest, and then every 5 minutes, okay, during the course of the workout, because no vital sign on its own is valuable to you. It's only valuable as we see the trend, okay, and as we see it over the course of time in different activities. Our program consists of breathing retraining, so pursed-lip breathing, diaphragmatic breathing, paced breathing, recovery from shortness of breath, but again, that's not the treatment alone, okay? Aerobic exercise, strength training, flexibility exercise, arm size. You guys have arm size here? Do you use it all? Great upper body activity for patients. Many pulmonary patients have a lot of trouble with upper body activity because it puts the respiratory muscles at a very poor mechanical advantage. So that's why people say, oh, the shower is terrible, I get so short of breath, which is the other reason also why when they fix their posture, they can breathe better. Okay, normally the muscles of our chest, back, thorax, do things like this. When we close the chain, they work in their reverse action to elevate the rib cage and assist with breathing. This is why people say, I don't understand why I can walk on the treadmill, but when I get outside, I can only walk a half a block. If you give that person a rolling walker or some walking sticks, they will be able to walk further. All right, adjuncts, airway clearance unit, orthopedic and manual therapy, and this is my webinar series where these are the things we focus on. I just want to show you a couple of videos of some of our patients, and then I'll take questions. Okay, sound. Here's the sound. Where? I'm not seeing it. Make it louder, Wayne. Crank it. Let's bother the neighbors. So another thing, you want to make it fun for people. You want it to be boring. You want it to be social. You want people to come and feel like they're having a good time and getting benefit. Otherwise, they're not going to come. So this is arm size. So this is a series of 15 exercises, and I'll also make these available within the presentation. So you can look at them if you want to be patient, because this is, this can be done anywhere, can be done everywhere. Can be done with no equipment. This is our center, this is our staff. We started off at... Every once in a while we get someone who goes rogue. All right, so this guy is he's going at 3.5 miles per hour, 15% incline. He's 90. Okay, so a lot of you here, we'll put you on the treadmill 3.5, and he turned 90 since then. Yeah, how do you feel? Terrible. But he does it, and it's because he exercises a lot. That's what they all say. Big hands out of your pocket. Act like you're interested. Once our patients have been here for a certain amount of time, we require them to dye their hair the color of the center. All right, so this is a gentleman with IPF, okay? We load him up with as much oxygen as he needs. I've seen programs where they will lower the workload to match the oxygen saturation. That makes no sense to me, okay? If your daily life requires this, and we exercise you here, you could do that till the cows come home. It's not going to make your life any better. If this is what your life requires, you'll do whatever it takes to get you up here, and then you're going to get better. And again, a lot of times it's not the COPD that's causing the discomfort, it's conditioning. And we know that based on the exercise. And here's another way you know it. You know, when you talk about pulmonary rehab, if you read the classic literature, they'll say patients feel better, they're less short of breath, they can do more, but there's no change in pulmonary function, right? So I do believe, I've seen a ton of cases of pulmonary function. I think the reason why most people don't get improvements in pulmonary function is because they don't work people vigorously enough. But here's something to think about. If you feel better, if you can do more, if you can, if you're less short of breath, but there's no change in pulmonary function, then what that tells you is that it wasn't your lungs, that it's other factors, right, that are making you short of breath. All right. Here's one more I'll give you, and then I'll take questions. Say hi to your family and friends. See, we don't work in a hospital. We can do anything we want. No one ever gives us any crap about it. All right. So, just a couple of other just minor points. So, why don't patients get referred to rehab? They're too old. Okay. This lady, you know, is 90 years old. Okay. Look at her walking on the treadmill. She's doing 9 meds there. Okay. They're too young. This guy's the guy who you saw before. All right, so this is a classic netter, too sick, there's no such, you know, of course within reason, but don't say it's too late. It's never too late. If you're still alive, if you can breathe, we could always do something, unless you're doing everything right already, and most people aren't. So there's always something. You're not sick enough for rehab. One of the stupidest things I've ever heard. It's like you're too rich to save money. The cancer's gone. Just because you've had surgery doesn't mean you need rehab. One of the biggest mistakes people make after lung surgery is that they tell the patients all you have to do is walk. The patients feel fine after surgery, but then we see them 3 months later after they hadn't moved their arm at all because of pain, and now they're bound down. They're getting chemo or RT. I believe people should work through those things. Of course, you may have to modify the program, but I think there's benefit to it. They still smoke. I think a big mistake people make is saying we don't accept patients until they quit smoking, because those patients never come back. I'd rather take you in, get you motivated with the exercise, and coach you along and shame you into quitting while we have the exercise. No pulmonary rehab. So this guy's 97. The guy in front, I mean. So this bike, this is a stationary bike, so it doesn't even have any wheels on it. So it's like, I just pushed him across the gym. And he's loving it. He thinks he's riding the bike. We didn't tell him it's stationary. All right, so I send all my patients to rehab. A lot of doctors think that they send a lot of patients. They don't usually get to us, or they don't often get to us. If all the patients who should get rehab did get rehab, they'd be wall-to-wall standing there like sardines. All right, questions? I know there's only a few minutes left, sorry, but there is a lot of material. Questions? Yes, sir?
When do you get them exercising on their own?
I would like people to exercise. I'd like to see them exercise at least 5 or 6 times, because just because I see them the first time they do a test, they may be fine on the test. I'd like to get a little sense of what their body does at different levels of activity. But walking should start right away. We give them arm size within the first couple of weeks to do at home every day. You know, I liken it to a savings account. So the more you do, the greater reserve you're going to have. So, but working out on their own, our program is generally 24 sessions. After that, people have the opportunity to continue with us or join a gym. But I think, you know, we're only seeing them twice a week. They need to be doing something every day. Mike?
Are all the activities on treadmills and bikes, are they all monitored?
Everything is monitored. Everything is EKG. I'm sorry.
No, they're on telemetry, right?
Mhm.
It's on telly. So is there someone with them?
Yes.
Yeah.
No one's coming in and exercising on their own. Again, it's my preference, okay? I want it to be safe. I want to sleep at night. You know, now there's a lot of talk about telemedicine for COPD. I know there's one program somewhere that does, you know, Skype rehab, okay? But my feeling is like, if God forbid something goes wrong, what do you do? Hold the computer up to your chest, you know what I mean? While we, you know, to me, I want it to be safe. I want to risk stratify. I don't want somebody falling off the, I mean, there's a lot that could go wrong. Now, a lot of places you go, okay, basically based on the nature of insurance, where it's gotten so per payment and they allow up to 6 to 8 patients in a class with one clinician, it's very difficult to do this same level. You can't monitor them in the same way. It's just impossible. I think we also generally see a little older group of patients, a little sicker, a little weaker group of patients. But yeah, we're not going to be able to get the most out of every session if they're kind of off doing it on their own. So I want to get you up, I want to get you resting bottles, I want to get you started, I want to see how your body is responding, I want to push you, I want to squeeze every drop of juice out of that session that I can.
So you say you give people as much oxygen as they need. Here in the hospital, we generally don't switch the amount of oxygen delivery until we confirm it with a physician. But, so who determines in your center, like, how much oxygen that patient should get?
We do. I mean, we know the docs, they know us, they give us an order that says titrate oxygen for 90% if we need it, but it's, yeah, I mean, you know, I don't want to say anything incriminating, but no, I'm just kidding. But bottom line, it's based on your saturation, and that's how it should be done, you know what I mean? It's like, again, it's like you have to look at your instruments, okay? Because again, the patient could look great, or like, here's another thing, so the patient can be, you know, rate very strong in terms of shortness of breath, and we check their saturation, and it's 97%. So use your instruments, okay, and check the things regularly. But again, if you start exercising and you go down to 80%, we have two choices. We either lower the intensity of the exercise, or we stop the exercise, or we increase your oxygen. And to lower the exercise to what you can currently do now, why, to me, that defeats the purpose of rehab or exercise.
Does postural corrective exercises play a role in your rehab at all?
It does on an individual basis. I'm glad you asked that, because I meant to talk about before, like, treat the patients as an individual. There's no one, and you know, it sounds obvious, but it often doesn't happen. So there's no one pulmonary rehab program for every patient. So if you have a 90-degree kyphosis, then of course that's got to play a role in it. We also have a musculoskeletal component of our program. We do orthopedic PT, but not to anyone outside, only for our patients who really, you know, maybe develop an issue while they're there, or we feel can benefit from that. But absolutely, posture is everything. I mean, just even like look at the idea of just turn your hands up like this, and all of a sudden you're breathing better. So definitely a huge role. Other questions, comments?
Your
Mike?
staff, can you describe your staff?
Very nice people. We have one Indian, one, no, my staff is made up mostly of physical therapists, so I would say we have 5 physical therapists, 1 PTA, 1 exercise physiologist. 2 of my physical therapists are also physiologists. That's my staff. So, and again, you know, when you think about classic pulmonary rehab, like I'm a physical therapist. I run a physical therapy practice. It just so happens I treat cardiovascular and pulmonary patients, but trust me, I've been through the ringer with the government. I never lose, because there's other reasons why we can see it. You know, there's no patient comes in with one problem. Every patient has comorbidities, but you have to really, treat each patient as an individual. And you know, the physical therapy practice of it, if you look at the classic definition of pulmonary rehab, they'll say it's a multidisciplinary team led by a physician, but it really doesn't have to be. You know, which is not to say physical therapists can do it all, occupational therapists can do it all, or one doctor can do it all, or one nurse. My point is, learn as much as you can about the different things, the stress management, the relaxation training, the medications, because one person, you know, who knows about a lot of these things are much more valuable than a whole team of people who have a vague idea about it, or who don't really love what they do.
As a teaching hospital, we have a lot of staff that are coming in new,
Yep.
new grads, whatnot. One thing that you would advise new staff as they're treating any type of patient, maybe in particular cardiopulmonary, that you would advise?
I would advise, certainly, you know, regardless of the patient, check vital signs, okay, pre and post. And if if you're treating patients that have been bedbound for a long time or the ICU, maybe serial measurements. So lying down, check the blood pressure. Then have them sit up, check the blood pressure. Then stand up, check the blood. We want to know what's going on. And like I said, unlike an orthopedic condition or some neurologic condition, we can't see what the vital signs are doing. So we have to rely on what we measure and what the patient tells us.
Thank you so much.
All right, thank you.